Hello, everyone. My name is Blair Mayu, and for week 5's topic of maternal substance use disorder, I will be presenting the drugs Subutex and Suboxone. Goals of this presentation include the knowledge that prenatal opioid use disorder is a national and public health threat, placing both the pregnant female and the fetus at risk for negative health outcomes. Medication-assisted therapy, Subutex and Suboxone. How to manage the medicated-assisted therapy in stages of pregnancy and in the neonate, and risk factors for both women and fetus. According to the Center for Disease Control and Prevention, in 2010 through 2017, the national percentage of maternal opioid substance usage went from 3.5 to 8.2 per 1,000 live births. Neonatal abstinence syndrome is a neurobehavioral condition at birth that can happen in response to the withdrawal that neonates experience from their exposure to intrauterine opioids or the medications that is used to treat maternal opioid use disorder. And in 2018, it increased from 4.0 to 7.3 per 1,000 live births. My home state of Massachusetts, opioid addiction has caused a public health threat with an increase in over 500% in deaths that are related to opioids since the year 2000. In 2019, the state of Massachusetts had 11.7 per 1,000 live births diagnosed with neonatal abstinence syndrome. I actually work in a level 2 nursery in the southeastern region of Massachusetts. And in that same year, we had 19.4 per 1,000 babies born with NAS. So as you can see, that's well above the national average. So opioid use disorder during pregnancy is from an individual who's pregnant, who's using drugs on the street, such as heroin or fentanyl, or from misuse of prescription opioids, or from a combination of all of them. During pregnancy, if the female is not treated and continues to use heroin, there is an increased risk of fetal growth restriction, abrupto placenta, fetal death, preterm labor, and intrauterine passage of meconium. Opioid use disorder during pregnancy also has complex social factors that tie into drug-using risky behavior, such as needle sharing, sexually transmitted diseases, smoking, lack of proper nutrition, lack of access to prenatal care, violence, prostitution, and/or homelessness. In addition, a pregnant female with opioid use disorder using during her pregnancy is also highly at risk for overdose. Opioid use disorder treatment during pregnancy. A pregnant woman who uses opioids, or she has a past medical history of substance use disorder with opioid use, might benefit from participating in FDA-approved opioid dependence medication-assisted therapy with methadone, Subutex, or Suboxone. It is important to note that drug therapy should be in addition to increased medical visits and diagnostics during the pregnancy, as well as social and mental health supportive services. Treatment with Subutex or Suboxone can be prescribed in an outpatient setting that results in higher compliance and better health outcomes when compared to methadone. Furthermore, Subutex has been shown to have less babies born with NAS syndrome. Monotherapy with Subutex. Monotherapy is the first line of therapy for maternal opioid use, and it is a daily dose of Subutex, a partial opioid agonist that helps suppress the acute opioid withdrawal effects that negatively impact the health of the fetus. In addition, it lowers the risk of the mother to continue with risky substance use behavior, placing them both at a higher risk for negative health outcomes. Unlike methadone, patients that are candidates for Subutex need to be able to understand the importance of self-administering daily and adherence to that treatment regimen, because there's less point of interactions as there would be with methadone taken daily at a clinic. Suboxone. Another medication for MAT is called Suboxone, and this is a combination of buprenorphine and naloxone, which is not often used as a first line of therapy for opioid use disorder in pregnancy. This combination is used to help prevent an individual from overdosing if they were to abuse the drug, as it has naloxone, which is the opioid antagonist, which is a blocker. Monobuprenorphine, the Subutex, has been preferred because it limits fetal exposure to additional compounds. In addition, naloxone has concern of fetal withdrawal if it is injected and abused by the mother. And in animal research, it is shown to have a potential for mixed hormonal and behavioral effects. So initial assessment. Care is very specific to the woman with opioid use and disorders, but the following slides are important guidelines to consider throughout her pregnancy. The providers should be aware of the complicated lives that a pregnant woman with opioid use disorder lives, and that includes a very thorough initial assessment with full medical, psychosocial, as well as social and environmental assessment. Care provided should be trauma-informed care utilizing motivational interviewing and empathetic and non-judgmental to aid in the development of a strong patient-provider relationship. Screening for substances should be implemented and used tools such as the 4Ps, NIDA, Quick Screen, and CRAFT if over the age of 26. An initial urine tox screen should be done and performed to monitor for non-prescription opioid use, and ideally it should be done weekly, but in the United States it's done at least 8 times while being treated minimally. So antepartum, ultrasounds for fetal assessment, in addition to the first trimester, should also be in the mid to second trimester, and later if intrauterine growth restriction is suspected. Retesting for STIs and planning for the delivery and discharge, which would include a multidisciplinary approach with consults for anesthesia to plan for pain management during labor, consultation with behavioral health, social services, and addiction services, also consultation with neonatologists and pediatricians for caring for the infant post-delivery to assess for neonatal abstinence syndrome. So postpartum, during this stage, women taking Subutex typically stay on the same dosage throughout pregnancy, and even postpartum, which is unlike methadone, where usually it's increased during pregnancy and then increased postpartum. They often continue this same dose for many years later. Education is very important for them about, the risk of overdosing if they are to use again, continue to screen for depression, and educate on relapsing and the importance for continued support services. Neonatal abstinence syndrome. So when a pregnant mother uses the opioids, as I've said before, or illicit drugs, or is being treated with OUD medication, their baby is at risk and is expected to have neonatal abstinence syndrome. And this is a neurobehavioral condition at birth that can happen in response to the withdrawal that neonates experience from their exposure to the opioids or medications that were used to treat the opioid use disorder. Clinical manifestations of NAS include disruption in their gastrointestinal, autonomic, and central nervous systems, and it can range in a wide variety of symptoms, including increased tone, irritability, unable to console, and poor feeding techniques. Screening tools such as Eat, Sleep, Console or the Finnegan tool can help determine their withdrawal symptoms and decision for the neonatologist to medically treat the infant. Interestingly, new research has suggested that if a mother is being treated with medication-assisted therapy for her disorder during her pregnancy and also consumes nicotine or selective serotonin reuptake inhibitors or benzos, it might raise the severity of her baby's neonatal abstinence syndrome. And that's it. And here is my references. Thank you everybody for watching my presentation. If you have any questions, you can email me, and have a great day.